Hi everybody, and welcome to our next infection control update with Marg. My name is Jenny Pearson. I'm part of the education team for the Primary Health Network. Just before we start, I'd like to acknowledge the traditional custodians of the land that we meet on today and pay respect to elders past, present and emerging. We do have another infection control with Marg this year. It'll be on the 16th of December and it's Christmas and infection control. So I hope you'll all be able to attend that one. There'll be a survey pop up at the end of the webinar. If you can please complete it, we would very much appreciate it. And if you have any questions, please use the chat box in GoToWebinar that will be on the side of your screen. Thanks, Marg.
Okay. Thank you, Jenny, and welcome everybody. Some of you are probably tucking into a can of tuna. Some people might be sitting down to a 3-course lunch. I doubt it. Now, speaking to you from Melbourne, and do not look at my hair, but I have booked in for a haircut. I'm sure you know the hairdressers were able to open from midnight yesterday morning, and I still have to wait another week. So really sorry that you're seeing me today, but look, this is life. Not really complaining that much, but anyway, one of the first things I can address, which comes up as a question down here all the time, and I know that you guys are spread over the PHN, which is a massive size, but you know what? You're one truck driver away from a case, from an outbreak, believe you me. So this is in fact what happened to us with the Shepparton outbreak, which is a couple of hours north of Melbourne, led to 3 cases. The guy, sorry, that's the rubbish bin collecting outside if you can hear crash and bang, and they're all my wine bottles, okay? Really sorry, but we're drinking a little bit more in Melbourne, sorry. With Shepparton, look, a couple of things happen. With contact tracing, they'll do a first round of questions. Where have you been? Who have you been with? How long? Where? You know, inside, outside, etc., etc. So for people like me, I keep a diary, not that I'm mixing with like anybody except my husband, but you know, you meet somebody at the park, or you walk around the park with somebody, you meet somebody at the front gate holding a cup of tea. I record all that. I'm not expecting you guys to do that because it's not proportional to risk. But think about your phone and think about your diary, and even if you just pencil in, I tell you what, should there be an outbreak there in Armidale, Newcastle, wherever, and you've got a list of who you've been near, I tell you, this is gold. Not everybody has the app. My stupid phone, you know, won't take it, etc., etc. My fault. So keeping that, and because we're healthcare workers, we actually sort of have that extra responsibility to keep our patients safe, our family safe, etc., etc. Because I tell you what, once somebody has to have a swab done in your house because they've got symptoms, you've got to stay home till the results are known. Now, we've got that testing and contact tracing down to 24 hours here. It's been a massive change. We've gone from a paper system with 3 days to trace a contract down to 24 hours. Of course, we can do that with low numbers, but what would normally take, you know, the department 3 years to do and plan for has been done in 3 months, to the point where the other states are also updating a lot of their stuff. So out of bad things, good things can happen. And it's so good to see the 3 health officers from those 3 states, Queensland, New South Wales and Victoria. I listen to them all every day. They're all really good people. And we know that this is not a time for politics. So always listen to your Premier who's taking advice from their Chief Health Officer. Yep, some decisions are sort of line ball, but really that information is gold. Can I urge you not to be complacent? You know, people thought in small towns we're okay. It's a Melbourne thing or it's a Sydney thing. Believe me, one truck driver away. So the way you conduct yourself ongoing, because I think we're only about not even halfway through this. So I don't mean to depress you, but hey, we've been doing the hard yards. You could say that we brought it on ourselves, but I think Victorians are pretty skilled up, especially people in Melbourne, at knowing what to do. So you know that we wear masks when we leave our houses, whether we're walking in the park or inside, and that's actually going to be a feature. So please don't be surprised if at times you're asked to wear masks. Okay, we've managed to do it. Okay, lots of you already wear masks. I say 2 hours for a mask is about your limit in terms of having to change. So we know with the surgical masks, really after 2 hours, we know that as soon as they become damp and wet, they're not effective. So use that as an opportunity to rehydrate, go to the loo, go outside, you know, get some fresh air. And then put your new hands, etc., put your new mask on. I don't think you guys have to wear face shields. I would, but I'm in Victoria. We have to. And I actually think, do not forget, this little blighter, there are receptor sites on your conjunctiva as well as the back of your throat. And everybody here is wearing face shields in that, because that is proportionate to our risk. I don't know when they'll ever step that down. It wouldn't surprise me if they don't. So where are we at in October in our district? This is your risk. Today I saw your figures. So there are 10 cases, 8 from overseas, 2 locally acquired. So what happens is there will be, on a day by day, and it changes, an increase and a lowering once we find out where the mystery cases come from. We call them mystery, you can call them unknown. We don't know where this person, they've got it positive, and we don't know who they got it from. We've asked them questions. In time, we might learn who it comes from. So you see those numbers bounce around. Your risk are your 2 mystery cases, and eventually somebody who's in quarantine, who's a positive, there will be a breach. I'm telling you about human nature. We're learning that. We've learned the hard way. So you saw there was a breach in WA in the last week. The 2 guys, the vets, got off the ship with all the, you know, one of those sheep moving off Port Hedland, and 24 crew positive. Those 2 vets walked into their community in WA, no quarantine. Huge breach. Watch this space. What I'm saying is normal things like what happened here, security guard might toss, or a person being taken out for exercise, because we actually were taking people out for exercise. No other states were. And I think you know why. There was a suicide, and I think there was a lot of nervousness. Look, somebody who's positive throwing a cigarette lighter to another person, something as innocent as that. And of course, this bug is only looking for your throat, your eyes too, but mainly your throat. So this is now down to human nature. And so what we've found is where we can't find where this person has got a case from with the contact tracing, they go back and have another go, ask them other questions. And so what we found, and I think this is instructive for all of us, is that people who do cash in hand work very reluctant to say, well, actually, I was also there. So the government, you know, the DHHS say to them, listen, think of this as just like an appointment with your doctor. It's confidential. We're not interested in your arrangement with the tax office. We just want to know where you've been. So that's how we're closing down more of our mystery cases, because of cash in hand work and people reluctant to say. And secondly, people having maybe little dalliances on the side. And again, so there you go. This virus will catch you. So I'm not saying that has happened in every mystery case or in particular cases, but it's about when the contact tracers come to your door, it's about being fully open. And if you've got your little diary also, even if you've been shopping or you've been to a hotspot, then you've actually recorded it. Some people use their phone. Fantastic. Okay. So where we are at is you are in a big region. So it's really so many different districts, but keep your eyes on those figures. Those people in quarantine, for sure, one of them will belong in Armidale every few weeks. I'm sure you're getting somebody who's been 2 weeks in quarantine in Sydney coming back to Armidale. I think they're doing, you guys are doing a second test on day 10. I think ours is day 11 to clear people. We're actually, I think, also doing another test on 14, because we know that day 14, just a very small number of people are still shedding the virus. Whether they're shedding enough to infect others, we're uncertain. There is some work being done to show that even around day 6, after your first symptoms emerge, that as long as you're getting better, it's probably quite hard to transmit it, but we're just not taking any risks. People have asked with Australia, oh, isn't that fantastic? Well, you know, the numbers are so low, but we are going to have, I think you've seen the numbers today, 32,000 people wanting to either return or move or do whatever. Now, you can have different views about that. We know that people have got a right to return to their own country. But these people, yeah, they represent our risk because of breaches that are human, just as much as local, you know, a local version. So with the cases in New South Wales that are community, I'm assuming they are still from Victoria. What you would look for are the genomics. And so the genomics are where they can actually look at the RNA sequence and say, ah, that's from the UK, that's from India, that's from America, that's from Victoria. I am praying that your positive 2 that you've got today are the Victorian strain, okay? Because if they are the overseas strain out in your community, there has been a breach. So that's that's what I look for. They're the numbers I look for. So when people say, oh, you know, in Melbourne, why can't we be the same as Sydney? They've almost got less cases than us. Yes, but we've got, I think, 10 mystery cases, which means there are 10 people they got it from, most likely, who are walking around that we don't know about. So accept 2 things. 1, we've got 10 mystery cases, you've got 2, and yours will probably close out and be 0 almost by tomorrow. We might close down another few. We seem to be closing down a couple of mystery cases each day, but then of course another one might pop up. So they're the cases to look for. Your rolling average is important too. There was one more thing I was going to say, and it's just sort of slipped my mind. So how many mystery cases, and putting your, you know, a ring around those. So you would have heard last week the outbreak at Lakemba, and concern because people in those communities, I don't even know whether the patients were wearing masks going into the doctors. So I'm really hoping that you are insisting that patients wear masks when they are doing face-to-face consults. I would also urge you to really consider, because we are in the middle of a global pandemic. That was the other thing I was going to mention. Why are people saying, can't we open up, can't we open up, can't we open up, like completely? Well, what part of a global pandemic do Australians not understand? In that term, global pandemic. So the only way, and New Zealand might have been clear for a number of months, but there you go, they got cases back. So we're not really going, suppression strategy. But where does that get us? So if a state has a suppression strategy and won't let others in, that's a temporary thing. So, you know, we can look forward to those opening up of the borders, but you've also got to have rules that say, bingo, got to close today because, you know, this is getting out of control. So what we know about this virus is that for a couple of weeks, you might see very little. People have incredibly minimal symptoms. Young people, etc., might have so minimal, they think, it's only a slight tickle, I don't need to worry. And before you know it, 4 weeks have gone by and kaboom, and it's already got into your nursing homes and stuff like that. So it just moves incredibly quickly. There's some evidence to show that it is becoming more infectious. Not a high mortality. In fact, we're seeing, it looks like a lowering of mortality, but all we're seeing, in fact, are countries like ours invested in ventilators and ICU beds. So you will always see a low mortality here, only because we have capacity. But if there were no restrictions, there actually wouldn't be enough beds and there would never be enough ventilators. So it's really important that whilst you can't see this thing, we acknowledge we're in the middle of a global pandemic. So that's about Australia. So yep, we'll probably open up to ourselves, each other, etc. Still, you know, for Victorians, we'll be wearing masks for a long time and doing distancing, etc., etc. And as soon as there's a symptom. So there will be that sort of testing for symptomatic. So Australia-wide, what will also happen in different spots, and you'll see this in your town, is that the department swabbers will arrive and do what we call sentinel testing. So that is, they might say, Armidale, all of you come out over the next week and have a test. If you've got a symptom, of course, you've got to go and have a test anyway, but this is a different sort of test. So they do the test, whether it's a spit or a swab, and you might even do it yourself, but this is where we look at population epidemiology, and we say, you know what, we've tested, they might even say, people whose names start with M, turn up tomorrow to the showgrounds at Armidale, have a test. So what they'll do is this ongoing sentinel surveillance testing, if you like, and say, look, in this community, we've done 1,000 tests over the week, we found no positives, so there's no residual virus. So that's the other sort of testing that we do from time to time, but only when numbers are like really low and we want to see what's going on. The other type is, and you'll certainly hear about this, is that we're doing regular testing of high risk industries. Now, I hate to put aged care in as an industry, but definitely there's going to be regular swabbing. I think they're going to be doing everybody every month here. And so meatworks, warehousing, transport. Now that's only going to work if a boss declares who their actual workers on the books are, because they're all going to need a swab. So this isn't going to work if people aren't declaring who's working for them and doing cash in hand. So I think there's going to be some interesting issues there, okay? So that's the other sort of testing that we'll do those high risk industries, because we would want to know straight away if there is anything bubbling. And that leads us to talk about asymptomatic cases. So in fact, all cases will be asymptomatic at some point. In other words, some will go on to develop infection. They're what we call the pre-symptomatic people. And we know that a day, 24 hours at least, before the symptoms break, you are infectious, and for 5-6 days after that, as long as you're getting well. So getting that swab as early as possible, because that means the results come back in 24 hours and then we can chase down people that you've been in contact with. And can I say the only good thing about this virus compared to influenza is we don't even do contact tracing for influenza in a pandemic, because the incubation period is only 24, 36 hours. Here, we've got an average of about a 5-day incubation period, so we can get to people, the contacts, and even the contacts of the contacts if you've got low numbers, and ask them to quarantine. So the word quarantine refers to those waiting to see if they get an infection. The word isolation strictly are those who are in fact infectious. So you guys will probably hear that rolled into one as self-quarantine, self-isolation. I don't use that term, sorry. So where does that put us globally? Well, I think you've only got to have a look at the numbers. And I won't make any comment there, but really Melbourne is probably the first city in the world to come out of a second stage. I don't know whether it's a second wave, but a second go. Most places around the world aren't even doing contact tracing. They've got rubbish systems, and of course governments haven't invested in them. Not important. Who's going to plan for a 1 in 100 year pandemic? Nobody. So there's lots of sort of the human element. You know, we want to spend on roads and bridges and all sorts of other things, and who wants to care about a 1 in 100 year pandemic until it happens? So let's say we can declare Australia virus free. Well, how does that affect us with tourism? Because of course that will be the next request that everybody has. I want to now go overseas. You know, there's a lot. Think of the cruise ships. Can't wait to get here. I don't think I'll be booking, but lots of people will. But of course, cruise ships, what we see there is this enclosed area. You saw the crew, how they all share cabins, so it just goes like that. So we use this term transmission. We use for our different infections this term reproductive number, effective reproductive number. How many people would I infect? So if you look at something like measles, that's got a really high RO, and that's around 17. That means one person, highly infectious, can infect, you know, up to 17. As if you look at influenza, it's around 2. One person can infect 2. With this is what we've learned. We've learned that it's normally around 2, 2.5, but in cruise ships and similar situations, it can be around 4. So you can see why you just get an explosion. People are sitting close together. You know, they want to maximise space on those cruise ships. closer together. More activities closer together. A lot of indoor activities closer together. So there's just an explosion. So I'm not sure about the cruise ships, maybe yachting. Maybe yachting might be the way. So there are issues that Australia has to look at. You know, if we pat ourselves on the back and say, aren't we fabulous? All of our borders are open internally, then we've got the next stage. And I think you can see the ships that are coming in with supplies, you know, with our trade, they are the risk in Queensland and Western Australia in particular. So there has also been a move, and I think this is a good move, and I had this as a real issue with hotel quarantine. Where it was multiple story, I saw a problem. I saw the fact that people couldn't open windows because they were terrified of people jumping out too. But there was no fresh air, no ventilation. So speaking to you as people who work in clinics, why aren't your windows open? There you go. Fresh air, in other words, air exchanges. Forget ceiling fans, they're just going to blow the droplets further over everybody else. That's where there's a risk. If you ascertain, we're okay, it's nowhere near us, business as usual, and pop a mask on from you're not engaged with a global pandemic. So thinking about windows opening, thinking about, can I see my patients in their car? Can I see them outside? I can't tell you how many pop-up marquees there are in doctors' car parks around Melbourne. Lots of patients being seen in the car, lots of patients being seen in the marquee, and it's a last resort. Come on inside, I need to see you. But can you see that as part of a 20-minute or 30-minute consult, only a part needs to be done close up, and of course both have got masks on. So look at risk reduction strategies in your clinic, and I think Jenny sent out to everybody my cheat sheet, which is about patient wrangling, staff wrangling, and thinking about the environment of the clinic. I did mention that to do a deep clean, if you find that you've had a positive, there was one company charging a clinic $6,500. Everybody like that. So on my website, I've actually put a suggested protocol for you to be able to do what I call a deeper clean. But I tell you what, if you've got rubbish all over your clinic, it's going to take you forever and you're going to have to throw stuff out. So I've given you two protocols. One is managing my clinic in terms of cleaning and just putting stuff away. And we know who's really bad at not putting stuff away. We won't mention their names. Things have a home. Then are devices that are used on patients wiped down between every patient? I tell you what, if you can get all that stuff in underneath, then if you get a case, boy, it's going to be so much easier to not have to pay $6,500. Plus, nobody needs to come in a big white suit with a fogging machine. That's just ridiculous. That's the sort of rubbish that you see on the telly. So I need to sort of, calm people down there that we are very capable, and I'm always happy to oversee via Zoom somebody carrying that out. Some people want me to even look at all their high-touch surfaces, send me their policies. I'm really not that interested. But other times people just get me on Zoom for an hour and we walk around their clinic and I sort of say, well, this is how I would clean your clinic on a daily basis, and these are the high-touch areas I would clean and disinfect. And I tell you what, so many clinics have set their places looking fantastic now. So it's only taken us, a few years, but we're really good. So what might November and December look for us? Well, I don't think Melbourne will ever go into lockdown again, not now that we've got the strategies in place. I can't see Sydney having a mega outbreak like Melbourne because, there's been a wake-up call, can I say that, in all the capital cities. My concern is really for states that have been off the leash for a long, long, long time. How quickly would the citizens of those cities, Adelaide, Perth, etc., how quickly could they discipline themselves? Because I tell you what, it hasn't been really tasty doing what we've been doing in Melbourne, but people are behind the health officer, people are behind the government, doesn't matter what colour you are, but you can see that I think 60-70% of people understand. None of us like it, but we understand this is our way out. And not particularly feeling sorry for myself at all, But this is our way out. There is no other way. You can blame who you like, but let's get people's, let's get health sorted now. People who've called for restrictions lifting, I don't think they understand, because if we'd not done what we did, there'd be more mental health issues than you can believe. And healthcare staff, it's not fair that the public think it's okay to be a risk to healthcare staff when people finally get sick. In terms of the ages, it's really been quite sobering, the number of young people who've been affected by this. And the long haulers, you've probably heard about the long haulers, those who are still positive, who don't really recover. And there's a whole lot of them in their 40s, believe you me. And I've got a personal association there, a worker of one of our friends. The guy is still positive 3 months later. He's in his 40s, really fit, used to go swimming every day. And his presentation was actually neurological, and this guy's really battling depression big time. So don't sort of, this other notion, oh, it's just for old people. Well, thanks, throw me under a bus. I've been saying to people, you young ones, you need us, you need our money. We're the ones with the money, and you need us to part with it so that keeps you busy. So I kind of think it's a time to be nice to everybody, quite frankly. I really feel for the younger people who had those really tenuous jobs that were very casual, stuff like that. That's really hard. So a lot of us where I live are right into local business support, hugely. I can't tell you how many trucks turn up to deliver stuff up and down my street. Somebody's doing well, all right? You can even get restaurant meals delivered. I'm sure you're aware of that. So people are going nuts. And I can really sense this week there's a lifting in spirit, and I think that'll improve after next week. So ongoing measures, and what might Christmas look? Well, it's going to be very regional. So for you guys, there may be absolutely no restriction at Christmas time, but stay tuned. And when you hear, Armidale, your Christmas is going to be, outside, and you go, oh my God, roast turkey at 1 in the afternoon. Well, a lot of us are going to be doing evening stuff, I'm sure, when it cools down a bit. A lot of people will do breakfasts. I almost think we're probably going to go to a Mediterranean style life, and just, because it just gets too warm to congregate outside during the day. I think breakfasts are going to be more popular. I think lunches at home outside might be more popular, early lunches or late breakfasts. And then I think evenings are going to be about outside. So it's going to depend on what part of Australia, but certainly there'll be parts of Australia that have no restrictions at all, but the measures stay the same. Do not hug people outside, who you're not supposed to hug willy-nilly, because this is the way it's transmitted. It's just looking for a throat. Until you're told you can hug people, you don't. So so the measures are not really restrictions. The measures are keeping a distance. If you have to wear a mask from time to time, keep going. Listen to the restriction on numbers at restaurants, bars, etc. It's usually sit down, so you're served while you sit down. So the measures are distance, don't go out if you've got any symptoms. There's only one thing to do if you've got a symptom, that's get a test. And that's straight away, that's that morning, not tomorrow, I'll see how it goes, because then we've lost a day on contact tracing. Hand hygiene, can't tell you how important that is. We're touching our mouths 6 to 8 times an hour. In fact, it's increased. I was looking at some paper and they said it's more like 20 or 30 times an hour. And then cleaning surfaces. So that's the stuff we do in our life. For you guys at work, I can't imagine how much hand hygiene you're doing. So what is happening to us psychologically? You go, I don't see this thing anywhere. Why do I have to keep on doing that? Well, guess why you're not seeing it? Because we've been doing the things we're doing. It didn't sort of decide it wasn't going to go to Armidale or any of the other towns or major centres. It didn't just decide. This thing doesn't move. We move it. And the reason why you don't have it in Armidale or any of the other towns, etc., is because of, measures taken. And so that's really hard for human beings to get their heads around, because why should I, put a mask on? People are asking that in my suburb. You don't have any cases now. 2 today, be yesterday. I have to wear a mask. And well, why do you think we've only got 2 cases? Because we've been wearing masks and this thing is still here. So we will continue to wear masks. The only loosening up, I think, with masks will be we may not need to wear them outside. Maybe. Okay, that's the only sort of loosening I can see. I think controlling numbers of people who come to your house, really important, but certainly get cracking with making that outside area look fabulous with a shade cloth and a couple of palm trees, something like that. At work, do the same. Make a lovely outdoor spot for your staff to go and have their cup of tea, because I tell you what, if you had read the report from Tasmania where they had the big outbreak in April, staff come into the tea room, mask off, onto the table, sitting around in a huddle. One of the nursing homes here in Melbourne, staff actually came to work on their day off to have a baby shower. Actually came to work. That was a place that had, I think, 30 deaths. So make life easier for yourselves. Get that little 4-posted marquee up at the back and nice little spot for the staff to sit. Do your distancing when you can. Alcohol bottle on the table and have your cup of tea at there. So where you can distance, do it, because it actually matters. There are times when you can't distance, but you'll have your masks on. Okay. For your patients, again, a little bit of telehealth, you still need to come in, but hey, we'll see you out in the car or in our little marquee, and then look, yes, you still need to come through. So almost a triage, if you like, but just reduce it. So we know that close contact is 15 minutes face to face, and that would be, that's actually rolling over a week, cumulative over a week. So we've got masks on and that helps, but masks are not the full answer. So one person wearing a mask is about 40% protective, 2 is around about 80. Masks are not the full story. So it's about distancing, standing back when you can. It's about being outside. Being outside means I've got unlimited air changes. That's what we're after. So some of the clinics have said to me they're going to start opening up early and having a whopping break. This is in different parts of Australia, having a whopping break in the middle of the day and then having a very different shift in the evening and doing different things on different days. What does air conditioning do? Well, air conditioning and heating, if you have patients in your waiting room, nobody's waiting in waiting rooms here. So patients are called in from outside when the doctor is ready to see them. Sometimes the doctors go out and get the patient and they can sort of work out whether they need to come in, and the doctors can walk the patients back to the car and have that chat rather than doing it inside. And so people are finding, you know, where they've put their clinics into places where windows won't open, they're really thinking, well, what do I do? So you need to know how many fresh air changes your building gets per hour. I think it's supposed to get, for it to pass, it might be 3, it could be a bit more, but people are saying, I don't even know who owns my building. I don't know how many air changes, but air changes are important, or open the window. For doors, some of the clinics here have just put security screens on so the patient can't get in until it's time, you know, for them to be called. So as much fresh air, it's going to be hard in the summer, but all I can say is if I've got a receptionist and an admin out the back, then I don't want them subjected to people in the waiting room all day long when those patients can be called in. Okay. Also, obviously, checking the patient's symptoms. It's not enough to ask, are you well? People can feel perfectly okay with a bit of a scratchy throat and a cough. I think we need to go a bit further than that. Contactless thermometers, almost useless, but still use them, but accept that it's only a part of the story. So if the patient's on Panadol, oh, well, there you go, they're not going to show a temperature. If they're elderly, we know that only about 30-35% of people that are older will, you know, have a temperature with this. So it's very much also about the symptoms. I'm not asking you to go to a tympanic, but that's better, and an oral tympanic are much better than contactless. But remember, you can have trouble with contactless. People arrive hot and they come into maybe your air-conditioned building. I don't think there's going to be too much air conditioning in Victoria this year, so we're praying for a cool summer. But just bear that in mind. The contactless thermometer is not the be-all and end-all. And a lot of clinics say to me, oh, it's just easy, we just pop that on them. And I go, oh, sorry, that is just not enough. So be vigilant. Don't ever say it's not here. So this is what's going on in our head. I don't see it, it's not here. And it's not here. It's called the prevention paradox. It's not there because measures have been taken. So that's something that goes on psychologically. The other thing that goes on psychologically is, I'm okay. You can trust me. I'm very careful. You see, our self-assessment of risk is extremely low. You ask the people who, let's say we had 15 people last week, you ask the 15 people who swabbed positive last Wednesday, did any of you think that you'd be positive when you got your results? No. That's us. Even the 700 who tested positive 2 months ago. Any of you think you'd be positive? No. So very human. This is what you have to fight, but you're health professionals. You have to tell your family this. I'm okay. You know, I'll be all right. I haven't sort of been anywhere. You don't have to go anywhere. It is brought to you by somebody else. So there are those funny things that go on. The patients, oh, she's 85, she's been at home forever. Well, you know, she's probably been getting stuff on eBay, parcels delivered, nobody wearing gloves, wiping anything down, etc. So can't warn you enough. And it will, you know, you will get cases for sure. So keep up those measures. Don't go out when you've got a symptom. Get tested, the full length of symptoms, right through to nausea, vomiting, right through to foot rash. You should really know them all. Don't just ask people if they're well. And that's for us as well. So if anybody in my house is getting a test because they're crook, because they're symptomatic, I stay home. If somebody's just getting a test as part of Sentinel Testing, no, they haven't got symptoms, I don't have to stay home. Okay, so you need to sort of see that narrative of, oh, why are they testing in Armidale this week? Well, it could be just because they're wanting to know what's going on in Armidale. You'll know about it if there's a case, but this is what we will see as the next year rolls on. And these are the things that actually stop us going into a lockdown. Okay. So that's a little bit about what's out there. In Sydney, I would suspect you've got one person at least running around that we just don't know about, one or two. And you might go, is that all? I'll tell you what, one or two bubbling along and infecting others who don't get much in the way of symptoms becomes an outbreak before you, within 2 weeks, before you even know. And that's what happened to us in Victoria. I mentioned asymptomatic infections. And I mentioned, first of all, we divide that into pre-symptomatic, those who will get the symptoms. And so remember, there wasn't a lot of follow-up in the past where we just randomly swabbed people and found some that were positive. They weren't followed up to see if they actually got infection. So you read really interesting numbers about who never gets a symptom. It looks, just sort of me reading, that it's around 15%. But I have heard people quote 50%, but I think they're including those with very mild symptoms who really just, don't register. So 15% appears to be what's official, and that is very, very consistent with what we see with infection generally. So, yep, there'll be people who never get infection, but if you're keeping your distance and you're doing your hands and you're doing the things you're supposed to do, then that's why the measures are there, to take into account that there may be asymptomatic spread. So that's why we do that. Even in, in Varel, people think they're sort of, free of it. But as I said, you're one truck driver away. And I don't mean to pin it on the truck driver, but it could be somebody flying in for some other reason. This is the way it spreads. So I then wanted to talk a little bit about the cleaning, but have we got some questions? I think before we go on to the cleaning, etc. Any questions there, Jenny?
Yes, we do have some questions. So one of them was actually about checking patients' temperature on entry to the clinic, which you have sort of covered. Do you think you need to say anything else about that?
Do your contactless, but remember it's very limited. And unless you're asking people, are you taking, Panadol or anything like that, but accept its limitation. But if you do get a temperature from a contactless, it's a temperature, you know, it's a raised temperature. Some of the issues people have had around temperature taking at the front door is that people are hot when they arrive, have to wait for them to cool down. But secondly, the changes in temperature with aircon and heating mean you're having to recalibrate it, like, you know, all the time. So there have been those issues. But I think if I can speak to people just doing a little bit more on the symptoms, and I wouldn't be asking people to put it into a keypad, I would be doing it myself, okay? And I could say, I've asked you those questions, people can record whoever's doing it, and you just want to be no, and you say to people, look, it's best that you wait outside. I like that. Wait outside and we'll call you when the doctor's ready. Okay.
Is it possible to catch the virus again, and would it be as severe as the first time?
All right, well, there's two bits of research, but firstly, today we're treating one of our cases from yesterday as a possible reinfection. I think you're aware there's only been about 4 or 5 recorded or reported cases in the world to date. And again, rarely it will happen with measles, rarely it will happen with chickenpox. It is rare. So they've said, just to be as a precaution, this bloke, you know, or person, I don't know whether it's a man or a woman, has turned up with symptoms again, has been retested. So this isn't somebody who's had a long infection, you know, like our friend's drafts person who's crook, ongoing crook. This person has turned up with new symptoms, has been tested. So whether this is we're treating it as a true reinfection. You'd probably have to try and culture the virus to see if it's actually live virus in there. But they said for precaution, we're going to isolate that person for 14 days. So there's a real question mark around that, but it appears to be very rare. The other thing that people ask, I think, which is what this questionnaire is asking, how long does immunity last? So don't take too much notice of antibody levels. What we're really interested in with this being a viral disease is T-cell immunity, and there really isn't a ready off-the-shelf test to go for that. So T-cell immunity is really where those T-cells kick in and give any cell that's infected or tries to stop to the different types of T-cells, stop the virus getting in, stop the replication, and stop it leaving. So different sorts of cytokines, killer cells, all that sort of stuff. So the antibody levels, I'm really not guided by that. You've heard people say, oh, the antibody levels seem to go down after 2 months. Well, that's not what I'm looking for. I'm looking for T-cell immunity, not B cells. So it's B cells that produce antibodies, which are important. The IgM, which is one of your first immunoglobulins that are produced by B cells, that will start to rise at around about day 6, day 7. That's our early antibody, and symptoms should start to abate around day 6, day 7, and then IgG, that kicks in at about 2-3 weeks, and that will be sustained for a bit longer. So your IgM comes and goes in a few weeks, and your IgG comes up after a couple of weeks, and that's what confers some protective immunity. But we don't even know whether even the T-cell immunity will be long-term with this infection.
There's one more. Our clinic does not have opening windows and has ducted air conditioning with multiple controls. We are on the 2nd floor and there is no option to work outdoors. Can you comment?
Well, I could comment about where people have bought general practice clinics. I could comment about the fact that Florence Nightingale herself said, where the sick are gathered with a deficiency of light, space and ventilation, disease will spread. I could say that, but that sort of just sounds so old-fashioned, and public health is so old-fashioned. People have dropped infection control because it was public health infection control because it was from an era of smallpox and polio, and we don't have those anymore. So I think we need to shake ourselves up. Remember the term barrier nursing? Such an old-fashioned term. Well, you watch the healthcare workers on the telly from any country in the world, and you will see incorrect use of PPE. You'll see them with their cuffs over their gloves. Wrong. You wear your glove over your cuff. You've seen them. You'll see them with valves on their masks. Wrong. So it's all right for me. I've been doing this for 45 years and I'm finally useful. But, the investment was not put into maintaining that. And I know why a lot of our multi-resistant bugs have spread. And that's because people are just not skilled. You may be very skilled nurses and doctors, but you would have to admit that your infection prevention control has been rubbish. And I'm being really tough about that, but I'm actually quoting Lou Irvine, who's a respiratory diseases physician in Melbourne, and he said, I think my infection control is rubbish. So, a lot of doctors and nurses are relearning infection control, and it's not just doing your hands between patients, it's doing them after and then before the next one, because you're touching things. With your masks, it's about saying the only place for a mask when I remove it is the bin, not my pocket, not under my chin. So be really critical and call people out. The way people remove their gloves, sure, you've seen me do this 1,000 times before, but when you're removing your gloves, and of course I would always come to work short-sleeved, much easier to clean your hands, so I wouldn't this, so like this, that's the way you remove it. What do you see? People picking their fingers off. And don't forget hand hygiene. People again putting this enormous trust in infection control. Hang your hat on hygiene, hand hygiene, distancing, and your mask. Okay, not sort of like somehow people think the more they're dressed up, the safer they are. Can I tell you that 30% of the time that people use their full PPE, they actually self-contaminate themselves. That's how unskilled the Australian healthcare worker group is. And that's why they've introduced the buddy system here in the Melbourne hospitals to actually watch people. Now, that's really mean of me to say that you can't, do this, because your skill is in managing your patients and attending to their health. And so infection control is another layer on this, and we're just not used to it. We're not good at it. We've ignored those lessons when we were doing them in training and thought, oh, well, I've never really bothered about that in my patients, it's never happened. Well, we're being found out. So enough about that. But I watch people do hand hygiene. They're not doing it correctly. There's not, gloves are overused, and then people don't really see the need for healthcare. If you want to watch the security guards at the hotels, and I see them in the Sydney ones as well, putting alcohol onto their gloves. I don't even know why they've got gloves on. But putting alcohol, now they're just going to create little holes in their gloves, and they're not taught. The ADF, the police, infection control is not a natural thing. You've got to be taught it. So just because people say, oh, why did we have private security guards? Why do you think the ADF or the police would be any better? You've got to train whoever it is. I'm not saying they're worse, but you've got to train. Don't assume that because somebody's more highly qualified, that their infection control is going to be great. It depends what training they've had. Anyway, enough of my rant. Any more, Jenny?
No more questions.
Okay, so cleaning. I've got to be very careful mentioning brand names here, but this is how I would set up my little cleaning thingy each day. I would say all of us do cleaning. There's no precious princes or princesses in my practice, and we maybe have been really slack. Let's just say that we haven't been fabulous, unless you've got a clean freak or a, obsessive compulsive there. So first thing, get rid of your clutter. Everybody will love that. Things get put away. They get wiped over. If you're in the clinic, your oximeter or whatever, things get wiped over. Stuff that should not be out on the bench gets put away. Now, you might work with people who think the only good bench is a full bench, or there's something wrong with an empty bench. Okay, well, this is not the way you'd run, a healthcare facility. So what we know is that when you clean, you've got to wipe over all your horizontal surfaces. Well, if they're all full of boxes of this and boxes of that, then nobody's going to do a very good job of cleaning, and you're going to complain to me how bad your cleaner is. And I'm going to say, show me your bench. And if I have a look at your bench, I'll go, I'm not interested in cleaning that either. So make it such that your cleaner, or you, if you're the cleaner, has got a free rein, that you expect stuff to be put away. Can I just say, people are responsible for their own desk? For heaven's sakes, I wouldn't let a cleaner touch mine. Don't clean me out of my bench. I like my desk. That's mine. But I will clean over the keyboard and blah blah blah, etc. each day. Promise. But in terms of my consulting room, I'm thinking of my surfaces, my broad surfaces and my sink, my bench, and my couch. So they get cleaned over at the end of every day. Obviously, if there's any spillage, they get cleaned over straight away. But what have I given the person in that room to clean? So don't imagine for a minute that you would expect staff to go to the cleaner's cupboard and get the detergent and the whatever. No. So give people in each room their detergent disinfectant wipes, and they can wipe stuff down as needed, certainly for their equipment and devices. And so the requirement is that I clean and then disinfect the personally used items. So you can do that as a 2-in-1 step with not mentioning any names, but you can get a 2-in-1 clean and disinfect as long as the surface looks clean. So as long as there aren't any mucky bits on it, you can achieve that in one go. But in terms of cleaning your broader surfaces, your benches, your sinks, your couches, just a detergent, or you could use the detergent wipe again, but I think that's expensive. So these are the surfaces, the bench, the sink, the couch. You would say, I've got my gloves on, I'm going to clean, it's going to be done each day, and I would start with the cleanest surface first. So you've got to work out which is the cleanest surface of those three. Can I say the sink's always the last? Because it's wet, it'll always be the most contaminated. So you might say the bench. So you clean the bench with your freshly made up warm detergent and your disposable cloths, you know, the chucks on a roll. Clean the first bench, done, throw out that little cloth. The next one, so this is cleaning in the COVID style. This is not, you know, I've come from home with my rags and whatever, spray and wipe. We don't do that. So it's just a pour bottle, no sprays. Then I get the next one and I do the couch, and then I get the next one and I do the sink. Then I remove those gloves, do my hands, and I proceed to the next room. Okay, so you're really acting as though there might be something there. Now, do I now have to go and disinfect those surfaces? No, not particularly. But the surfaces that are high touch, yes. So I'd have one person doing the cleaning, normal cleaning, and then the floors last. Please don't put bleach on the floors. And then the next person would say, I'm doing the high touch surfaces. So that would be about us thinking in our practice, what are the high touch surfaces? Well, people touch the front door unless you've got an automatic opening. Fantastic if you do, or the door's left open, whatever. But the handles, the switches, the buttons, the Medicare, the underneath of the benches, you know, where people grasp like that. So high touch surfaces, going through my clinic, what are they? So you can allocate another person to that job. And honestly, that by the time you identify your 20 surfaces, it might take you 5 minutes to do. So that you go over that with you can also go over that with a detergent disinfectant wipe, as long as they actually look clean. But you can't apply a disinfectant to a surface that is dirty looking. So what a lot of people do is they say, look, I'm not interested in using one 4-cent wipe for every surface, but what I will do is I might fold it over, slightly cheating, or I might get some paper towel. And so a clean piece of paper towel with some detergent on it, go over each of those buttons and everything. Look, if it's a thick piece of paper towel, you might get away with folding it over and doing another surface. And then I'm going to come by with a product like, I'm thinking ViraClean, or one of these, more paper towel, and I'm going to ViraClean those high touch surfaces. So I would keep disinfection to my high touch surfaces, but I would clean all environmental, you know, horizontal surfaces and high touch surfaces with my detergent. So that's the way to do it. If it was an outbreak, well, go to my website and you've got to do a deep clean. You can see I've gone through that. I've had to more or less put myself through that. How would I do that with a colleague? And in fact, the first thing I do is open the windows, make sure the windows are open, and get ourselves out of that building. Send everybody off, transfer the patient contacts to another external computer, because those patients will need to be contacted by the department, etc. So anyway, I've written all that out. So where you don't have windows, you then say, right, how am I going to conduct myself? How am I going to make this the least risky? And if you've got two receptionists standing next to each other, even 1.5 meters apart, that's not good enough, really. I mean, why have we got two receptionists? Why can't one be in the back room doing phone? Because they're speaking and they're going to send more bugs into the air. And don't assume that people are negative. I've had one clinic where both receptionists were positive. And I was told they never, ever, ever got within 1.5 meters. And I go, yes, but why were they even there? Only one was needed to see the patients in and out. Why are we sharing Medicare machines? At my clinic, that's on a table in front on the other side of the sneeze shield. And so there's no touching. And I do my hands before and after I use that. They're the things to think about. So look at your whole clinic. And that's what I put in that cheat sheet. So windows don't open. Well, how is fresh air getting in? Oh, I don't know. You know, it's automatically set. We'll go and find out whether it's set to recirculated air or fresh air. Find out how many air changes there are per hour. This is your investment in your own safety, because nothing is good about being told you had a case this morning who's suspect or known positive, and you don't even know where to start. But if you had already set yourselves up to be low risk, it is so much easier, because we can even then say, patients never waited in the waiting room here. They only ever came in to see the doctor. Brilliant. So much less contact tracing, so much less worry. And don't think that this thing has gone. It is around for the next year or so. And if you're hanging your hat on a vaccine, good luck, because I'm not waiting. It's what we do now. So you might be able to do everything to make it risk-free, but you can do so much. But having patients in a waiting room, I don't even care if they're 1.5 meters apart. If you've got the aircon blowing over them, good luck. If they haven't got masks on, even worse. So look at all the things you can do. But it's not just mask and business as normal. It's how can I reduce the interactions even between the staff. Lots of people just go out to their car for their tea break, go out to the park, really good mental health break. Certainly think about changing your masks a little bit more often than you've been doing, and they need to be surgical masks, not homemade masks in your clinic. The patients can wear their own masks, but and you may have to give masks to patients. I wouldn't allow a patient in a clinic, quite frankly, without a mask right now. Outside, I might see the patient outside without a mask, but not in Melbourne, not in Melbourne. Okay, any other questions?
Yes, there's one that's just come through. The surgery I work for wants us to do a spirometry clinic wearing full PPE with patients booked an hour apart so that the room can be left for 30 minutes prior to cleaning. Should this be a disinfectant clean or a deep clean?
Why are you doing spirometry? I think there's actually some statement written about that. Unless there's been something that said that there's a return to spirometry, I wouldn't be doing it. So it's an aerosolizing generating procedure, as I think you're probably aware, and there have been some new guidelines written on that, and the sort of masks that you've got to wear. And I think you're supposed to be wearing a P2. No, P2 is only if the patient is likely to be a positive. But you know, just reduce the number of risky, unnecessary procedures. If it's a matter of life and death, that's different. But is a general practice the appropriate place to be doing spirometry? Go to the guidelines, because I know that this was really talked down, whether there's been a change and for different areas. It should be lifted fairly soon. So you might be ahead of me there, but really don't imagine this virus has gone away. And can you open the door? Can you open the door? If it's only the treatment room, lots of treatment rooms have got a back door. So think about where it's going to be conducted. For it to be just open to another patient an hour later, yep, you've got to wait that 30 minutes, or it could even be more, I don't know. So you are taking some precautions there, admitted, but just go back to the guidelines, because if it's not been updated, it was really saying spirometry no. So I'm happy to be corrected on that, but if I can make you go back to that guideline rather than ask me. And I think as a healthcare worker, I'd be wanting to shove that under somebody's nose and to say, really, we haven't been given the go-ahead to go to that, or there's been a decision made at the local level. So I would be asking my public health unit, is this appropriate to recommence? But certainly go to your national and state guidelines first and see what's what. And also be prepared for it to change during the pandemic. So right now in Melbourne, there'll be no spirometry done. Okay. All right.
That's all for today, I think, Mark. Thank you so much.
Okay, we're on. So I'll treat that as a bit of homework too. So the person who asked about the spirometry, I'll actually have a look at our latest as well, which should be, might even have been updated to September. But I'll have a look at the national guidelines too. All right, but definitely keep an eye.
Sorry, someone has sent through that they thought the Asthma Foundation had approved spirometry test out of Sydney.
Away, yeah, out of Sydney. Okay, beautiful. That's what I mean. Look for your regional thingy. I'm not going to advise you, you know, beyond staying with that. But yeah, it is a high risk procedure. Really question whether it needs to be done, and I'm sure you have, and you've got patients waiting. But have a look at how it can be made a bit safer. Certainly that hour is good, but how cluttered is the area? Can I clean all those surfaces? So you need a Marie Kondo maybe in your practice and get cracking there. So safe spirometry, but have a look at the place. So there are cardboard boxes hanging around everywhere, or is it done in somebody's room? Really nice if you can get a separate room that's really sparsely furnished. A lot of people have moved away from the textile chairs and have got those look-alike fabric chairs that you can just wipe over. So lots of stuff like that has changed, and I think these are good things to do. Carpet's been ripped up. Yeah, so opportunities to change things, go for it, and safe spirometry.
Thanks, Marg. There's no more questions.
Fantastic.
Well, thank you very much.
Right.
Brilliant as
Take
always.
care, everybody.
And we'll see you in December.
Yep, fantastic. See you later.
Bye.
Bye.